Good afternoon, dear colleagues in the Ukraine. We are here in the Netherlands with colleagues of mine, Jorge Lopez Mata and Zakia Akin. My name is Steven Slesvig-Visser. We all work on the intensive care in the Netherlands. We are very happy to make this webinar for you about acute echography, and we hope it will help you in your daily practice. We have no disclosures. We have made 3 movies for you, and you can look them up later, but it's also on the webinar. We are going to show you 9 or 10 windows. You see them here. We have 1, 2, 3 is cardiac windows. We have 8 and 9, that's pulmonary windows. 4, 5, 6, 7 is abdominal windows. And then you can choose to do the suprasternal window in number 10. On the pulmonary windows, I think in a traumatology, in your situation, you are mainly interested in hemotothorax, free fluid ruptured, aorta, pneumothorax, or dissections. For the cardiac windows, mainly you are interested in pericardial effusion, maybe RV, dilatation, cardiomyopathy, and again the dissection, and you might want information about the prelate or the filling status. In echography, we have different kind of planes. We have in green the horizontal plane, and in red the sagittal planes. We don't actually use the coronal plane. Of course, in your situation, you will use the ATLS principles of ABCD, treat first what kills first. In traumatic shock, 90% will be caused by hemorrhage in thorax, abdomen, pelvis, or long bones. Maybe sometimes you will see obstructive shock by tension pneumothorax or pericardial effusion or tamponade. In spinal cord trauma, you might see distributive shock and maybe rarely cardiogenic shock by ECS or Takotsubo. Echo is reliable and will help you to differentiate these types of shock. We will start with the normal cardiac windows and views and pathology, and my colleague Zakir will take it from here.
Yes, good afternoon. My name is Shakir Akin, cardiologist intensivist from the Hague Haga Teaching Hospital, and it's an honor to give this lecture to you, our colleagues in Ukraine, and we wish you all the best and good luck. From the cardiac view, we have pointed it as number 3 for the first window. Actually, that's the first number 1 in our opinion as an acute doctor from the intensive care. If you have a patient on a shock room, and you will and you should check subcostal view as first view on your echocardiography to exclude some dramatic pathologies. And we have aims in this presentation to show you all the echo possibilities in a patient, acutely ill patient, and from the heart, circulation and fluid balances, and echo of the right ventricle, and later on my colleague will continue with the lungs, and also quick look during CPR we will show. Echocardiography has improved technically in the last decades enormously, and from one point view from M-mode imaging, which is one line of ultrasonography which shows only the moving sides of the heart, which you can tell something about contractility, to 2D divergent ultrasonography signs to have an image of the heart, two-dimensional echo, which shows also the left ventricle, aortic valve, and in this parasternal long axis view, very nicely the heart itself and the contractility. So you can have an idea about the ejection fraction, and to the 3-dimensional and 4-dimensional even views, which are recently available from many echo machines. You can show all the parts in one window. We have in the subcostal 4-chamber view a lot of possibilities to exclude the pericardial effusion, to exclude signs of acute pulmonary embolism, which is right ventricle dilation, to exclude the septic hypodynamic heart or acute coronary syndrome of a failing cardiogenic shock with a dilated left ventricle, and to check also the inferior vena cava to show also the fluid balance or any hypovolemic shock, for example, and to differentiate between different pathologies. You can do it just easily by looking at the inferior vena cava, by sniffing. If the patient is awake, let them sniff, let them inspirate and end inspiration or acutely inspirate to show the collapse index of the vena cava inferior. You can calculate it also easily to have an idea about the right-sided pressures and right-sided volume overload. So just looking subcostal views, you can have a good differential diagnosis of a patient in shock, whether there is a hypovolemic or distributive shock, whether there is an obstructive or cardiogenic shock by a dilated right-sided venous return in the inferior vena cava. And we can also, just by converting or turning around 90 degrees the probe in subcostal view, you can see the baseline of the heart, so the axial short axis view of the left ventricle and the right ventricle, and see what the contractility is and whether there are signs of right-sided overload or right-sided pressure overload. And you can then after these views, which gives many information from the subcostal view, you can go to point first in our overview to parasternal long axis views to see below your probe, behind the sternum, right ventricle dimensions and the contractility, and the left ventricle dimensions and the contractility, beside assessment of the aortic valve, aortic root, whether there's an acute pathology in the aortic or ascending aortae, or in mitral valve or left atrium. You can see it in one view. And in turning the probe again 90 degrees clockwise, you can see at several levels, from aortic valve to left mitral valve to papillary muscles, to assess not only the contractility but also whether there are signs of severe valve regurgitations or not. By doing point 2 at apical view, it's very important to have your left ventricle apex below your probe, as you see here, to have a good image to assess left ventricle dimensions, right ventricle dimensions, and the atria. And by just tilling up the probe and pulling down the cable of the echo probe, you can see the 5 chamber by opening the aortic valve. And so you can also assess in this view the valve disorder or the aortic root enlargement for assessing, for example, type A dissection of the aorta. By this window, you have a good example of 4-chamber view by showing left ventricle directly below your probe, right ventricle as also the dimensions and the ratio of slim right ventricle and bigger, 2 times bigger left ventricle, which is normal, what is physiological. If you want to assess right ventricle thereafter, dedicate, and you have to go further on apical view to see the ratio first from the right ventricle and the left ventricle, and the anatomical differences between those 2 ventricles of high and low pressure areas. So you can measure right ventricle function and dimension from parasternal long axis to short axis to apical views, and when we started with subcostal views, then you have the best view of the right ventricle completed by doing this sequentially in different windows. So the cardiac pathology is not only in patients who are in shock, but further than that. Unfortunately, patients coming in during cardiac arrest being resuscitated continuously by a mechanical thoracic compressor like a Lucas, you can even exclude in subcostal view any pericardial effusion. So then you don't have to stop the cardiac or the thoracic compressions for this window, and it's a very good available window for assessment of pericardial effusion even during cardiopulmonary resuscitation. And if there is pericardial effusion, you will see that as a good black fluid effusion between right ventricle and liver area in. And then you can use also some markers as aortic descending aortae and pleural area to distinguish between pericardial effusion and pleural effusion. And this gives you also more idea about what the pathology will be. For example, if the descending aortae size is normal, and the ascending, there will maybe some other problems, whether here in this view we don't see any problems in the ascending or the descending aortae as far as we can assess in this parasternal long axis. But the pathology, what we have in acute setting in patients who are presenting with aortic pathology is most life-threatening is the type A dissection, and we have to be aware that there can be a big dissection flap in the aortic arch, but also in the aortic ascending, just in the aortic root above the aortic valve, which is also presenting with pericardial effusion. What we need at the end also a CT tomography of the aorta and the heart to help the thoracic surgeon to fix this problem, to have a to also fix the pericardial effusion. In some cases, when there is deteriorating hemodynamic status and maybe even a near CPR, you can need echo to even do a pericardial synthesis in these patients, but they are the worst cases in our clinic. In this case, we have time, even the pericardial effusion, to go to the OR. And as you see here, just by looking in parasternal long axis view, you can see a wide dilated aortic root, which loose of our sinotubular junction, and dissection flap, which shows clearly a type A dissection, which you see this in 2 seconds. Then you can be very fast after this to go to our OR. And after you have seen that, you can even check the amount of flap or the dissection flat in the aortic arch by using point 10 jugular area, and that's where we look downwards. We have shown it also in one of our videos, so you can check it again later after this presentation, where we look at the aortic arch with a common carotid artery and bronchocephalic vein to locate also the dissection. And when you look at the parasternal long axis view like this, and you see a normal aortic valve and also a normal sinotubular junction in the ascending aorta, then you have to assess also the descending aorta, because don't stop with looking if you see in the pericardial area normal heart or valve structures, but please look at the descending aorta, which is placed in the left thoracic area, and to exclude also a type B dissection. So if we further go back to subcostal area to differentiate between right ventricle overload or fluid or pressure overload, we can just use in our talks the normal view of the heart, where right to left ratio is below 1/3, and if it gets 1:1 or even 2/1 in ratio, then you have to be aware that there is a pulmonary embolism which increased the right-sided pressures enormously. And you see the dilated right ventricle, which causes also the D sign in the left ventricle, which prevents the left ventricle from good filling, good venous return, or left ventricle filling pressures to perform any cardiac output which is needed for your circulation. So in this view, apical view is even not any possible because of the right ventricle is dominating the area. So you can't get a normal normal apical fourth chamber view with a good left ventricle below your probe, but the right ventricle is enlarged and it gets more space, and it is a good sign of pulmonary embolism. Like you see here, right ventricle is much bigger than the left ventricle, or much bigger than the normal size, and it gives also in the parasternal short axis or the subcostal short axis the D sign. So there is a diastolic, but normally for in 99% is a systolic D sign because of the pressure, acute pressure increasement in the right side of the heart by pulmonary embolism. And you will see at the end, if you go with filling this patient with fluids, you will get more problem with as well as diastolic as systolic D sign. So you will get more severe shock if you have inadequate filling management in these patients. So be aware of the problems of giving fluids to these patients with already high right-sided pressures. So even in these patients, you have to perform a pulmonary CT angiogram to see amount of the pulmonary embolism and to manage your process or shock management, optimize your shock management further in these patients to decrease the pressures from the right side, to give the left ventricle more space and time to filling, to increase your cardiac output at the end. So that what we see here also with a moderator band here, very obvious is the moderator band in the right ventricle, which you see by enlargement of the right ventricle and the pressure overload, which increases the ratio right ventricle to left ventricle size. And this, again, the D sign, which is developed by high right-sided pressures. And at the end, we have also in many times patients who are acute or chronic failing in left ventricle function. And those patients who are known with chronic heart failure, they can present themselves also as acute on chronic heart failure, which is already shown in on the chest X-ray as a big ball in the thorax, and on echo for chamber view with a very big dilated left ventricle, which more than 55 millimeter. And even in moving files, videos, you can see also the spontaneous contrast in the left ventricle with a progression of the decompensation coitus. In other patients with stress, you can get, you can sometimes find Takotsubo cardiomyopathy. That's a stress-induced cardiomyopathy, which can be physical or mentally developed. And these patients who has disorders, EKG, there's many times a ST elevated myocardial infarction signs on the EKG, and when you go to cath lab, you will find non-obstructive coronaries, and in the LV angiogram here left above, you will see ballooning apical left ventricle, which we can also show on the four-chamber echocardiography as a non-moving akinetic apex of the left ventricle, which is ballooning, which is not moving anymore, except the baseline of the heart is moving, and the right ventricle is quite normal in movement.
Dear colleagues in the Ukraine, welcome to our webinar about acute echography. This is a joint venture of the Langhans Ziekenhuis, Haga Ziekenhuis, and Leids University Medical Center. We are now located in Haga Teaching Hospital. First of all, we would like to give you warm wishes and our support and we hope this webinar will help you in your work. What we are going to do with our patient here, we will show you 9 or 10 echo windows which are useful in the acute setting when you have a patient in shock and or respiratory distress. We will show you all the windows, and of course in traumatology the main cause of shock is hemorrhage. So we will say something about that. Sometimes we have obstructive shock, sometimes we have cardiogenic shock, but it's mainly hemorrhage. Echography is very fast, it's very reliable. There are some pitfalls we will tell you about, and it's fast. So we will just start showing the several windows now. My colleague here from Haga Hospital, he will start with the cardiac windows, and we will talk about those. All right?
Thank you very much, Steven. Let's start with the cardiac windows in acutely ill patients.
We start in shock patients. We usually start with the subcostal view, as you see my colleague doing here. What is very important is the direction of the probe. He is directing the probe in the direction of the heart. Often there is a mistake that the probe is done too much to the back, but it's really a transversal oblique direction. The marker, you can see it in his index finger, is on 3 o'clock. If you look at the screen, you see a very nice picture. We call this a 4-chamber view. Below you see the left ventricle, maybe you can point them out, and you see the left atrium, and of course in between the mitral valve, and then on top of that is the right ventricle, which my colleague is showing now, and the right atrium, and in between the tricuspid valve. Of course, this patient has no pericardial effusion. From this view, we can rotate the probe 90 degrees anti-clockwise with a slight tilt, and with this view we can see the vena cava inferior. And what is very important with this view is that you see it ending in the right atrium. We call it a golf stick. That is your assurance that it is indeed the vena cava inferior. And this gives you important information about filling. For example, in hypovolemic shock, it will be very narrow, and in obstructive shock, it will be wide. You can put an M mode in this. Maybe you can show that, Zakir. And in an M mode, you see a cross section of the vena cava inferior below, and you can calculate the collapse of the vena cava inferior. And you can look at the dimension in inspiration and expiration. Of course, this patient is well filled. You have calculating tools for that on your echo apparatus. So this is the second view in the subcostal window. We are now going back to the 4-chamber view. And from the 4-chamber view, if we rotate the probe clockwise 90 degrees, other side, I think, Zakir, we can actually do axial windows, axial views of the left ventricle. This is a very nice view on the right side of the left ventricle, and you can actually walk through the ventricle from the apex. So this is really the apex, and you can go upwards by tilting slightly towards the mitral valve, and I think the mitral valve is coming now. Is that the mitral valve?
It's a little bit
well, we
impatient.
need some patience.
Yeah, we are coming.
This is a very nice view of, I think, the apex of the left ventricle.
And there is the mitral
There's
valve.
the mitral valve, and actually, if you tilt it even a little bit more,
Yeah.
you might find the aorta valve. Other way around, I think, if you're lucky. And then you can actually make a short axis view with the aorta valve if you're lucky.
Yeah.
But
Yeah.
this not also works, not always works.
And yeah, in the middle is.
Oh yeah, there's the aorta valve.
Yeah, it's a very slim patient, so it's not easy to have it all in one point. The aortic valve and the pulmonary artery, and the truncus pulmonalis. Yeah.
Yes, very nice. Yeah, you can see the truncus pulmonalis there. Eh?
Yeah,
If there would be an embolus there, would you see it, Sakir?
yeah, you can see it. You can see a sign, and you can do a Doppler or velocity measurement in the truncus pulmonalis, and if there are high velocities in it, then that means there will be a gradient in it. So some object like a thrombus can be detected, or not directly, but you can get a sign of there is something wrong in the pulmonary artery.
Yes,
Yeah.
very nice. So in conclusion, the subcostal view will give you information about the left ventricle, right ventricle dimensions, about the possibility of a pericardial effusion, and about the filling status thanks to the vena cava inferior. It's important, preferably, that the patient does not have air in the stomach or the colon transversum. So you have to be a little bit lucky. Sometimes we first put in a gastric tube to get the air out. I think when next we go to the parasternal window, is that okay?
Aortic valve in the subcostal view only.
Oh yes, that's nice.
It's for sometimes you can see in color Doppler, if there is a sign of aortic regurgitation, you can think about something like aortic dissection.
Yes.
Okay, we didn't have a sign of pericardial effusion, but it can be an additional window.
So this is the subcostal four-chamber view position with the marker. This is the marker at 3 o'clock. From here we can rotate anti-clockwise 90 degrees with a slight tilt, and then we can see the vena cava inferior. From there we go back to the four-chamber view, and if we rotate 90 degrees clockwise, then we can see the axial views of the heart. That concludes the subcostal window. So now we go to the second cardiac window, which is the parasternal view. Cardiologists will begin with this window, but in the acute medicine we usually use it as a second. In this case you go on the left side of the sternum, you look for a good window. Usually you should go up and down the sternum, and the marker is directed to the right shoulder, so that's 10 o'clock. And Sakir is going to adjust the depth now, because in echography it's always important to see the whole heart, the whole image in your window. This window will give us the long axis view of the heart. And Sakir, maybe you can show the left ventricle. And then, of course, the mitral valve and the left atrium, the aorta valve and the left ventricle outflow tract, and then on top of that, the right ventricle. The right ventricle is very empty. It says something about your filling status. From the parasternal long axis, we can turn 90 degrees and we get axial views of the heart. So we now make a cross section of the heart. We shall play a little bit with the gain. It's always important to have optimal gain. And you can walk through the left ventricle and right ventricle from apex. This is the apex. And then Sakir will walk by tilting a little bit and show us the mitral valve. This is, I think, the mitral valve. And again, here we look at left ventricle and right ventricle dimensions. If you have very high right ventricle pressures, you will see a flattening of the septum. We call this the D sign. And eventually, if you tilt a little bit more, you can see the short axis aorta valve view.
In backside laying is always difficult to get the best short axis view, but we are trying, and you will see here somewhere the aortic valve in the middle.
It is not it's not uncommon to get lost in the parasternal short axis view, so when you get lost you always go back to the long axis. Maybe you can show that, Sakir.
Yeah.
So in this case we just try to find the long axis again, which we have found now. And from here you can continue your axial views if you rotate 90 degrees. But this can be quite challenging. In patients with pulmonary emphysema or asthma, it's quite often difficult to get good parasternal or apical views, and sometimes you can only get the subcostal view. And if you're very unlucky, the patient also has air in the stomach or colon transversum, and you get no cardiac views at all. So then you're a bit blind. Now we have a very beautiful short axis view with the mitral valve. As you can probably see, Sakir has gone down one or two parasternal spaces. So you really have to search for the best parasternal window. There can be great variability in that. So maybe we can now go to the third window, Sakir?
Yeah.
We will now go to the third cardiac window. This is the apical window. And usually you start your search around the left nipple with the marker to the left axilla. And cardiologists will always put the patient on the left side because then the heart is nearer to the thorax. Of course, in trauma patients this is not feasible, but we are very lucky because we have found a very beautiful apical four-chamber view. So maybe you can show the different landmarks, Sakir.
So the apex will be just below your probe. The left apex here, where the arrow is in the window on this monitor, and we see the left ventricle directly under your probe, and left atrium right atrium, and right ventricle, and just see the morphological differences and quite orientate where the left ventricle is and so on for your further marks for echocardiography of the heart. And so the contractility and the wall motions you can see in these views.
Yes, this is a beautiful view. Cardiologists will also put a Doppler in the mitral valve and the tricuspid valve, but I think for acute medicine this is not so important. From the 4-chamber view, you can also do the 5-chamber view by tilting the probe a little bit, and then you get the left ventricle outflow tract. I think again this is not so important for acute echography, but it's nice to have in your repertoire. Let's see if we can get the 5-chamber view. Yes. So it's just by tilting the probe a little bit like this from 4-chamber to 5-chamber. And you can go back and forth. And if you have serious pathology of the aorta valve or a serious aorta insufficiency with a color Doppler, you can see this pathology in this window. There are more views that you can see in this window, but I think it's not so interesting for acute echography. Of course, also a pericardial infusion you will see on this view very well, and right ventricle strain and other problems of the ventricle walls. Is there any more we should say about this window, Sakir?
No, not. It's enough 4-chamber view and 5-chamber view, and we can just go through by turning left sides or 90 degrees left for the 2-chamber view for further assessment of the wall motions. In case of acute coronary syndrome or post-cardiotomy ischemia on your EKG, you can check the wall motions by these windows.
Okay, that concludes our cardiac windows.
For the anterior wall, you can ask the patient to take a deep breath. Can you take a deep breath? And then expirate and hold on. Then you will see more of the anterior wall.
So at the end of the expiration, Sakir, yes. That's a very nice 2-chamber view with the mitral valve in the middle.
Yeah.
You can also put a Doppler in there if you want for serious mitral insufficiency. But again, this is, I think, less interesting for the acute setting.
Yeah. And then the 3rd chamber, by turning further on to 120 degrees, you will find 3-chamber view, and that's with left ventricle, aortic valve, and the mitral valve. So the left atrium, aortic ascending aorta, and left ventricle in one window.
Yeah, we continue with the pulmonary windows. Of course, in traumatology, this will be mainly about pneumothorax or tension pneumothorax or hemothorax. You see here several pathologies, but not all of them are acute pathologies. We start, just go back a little bit actually. We start with the pulmonary windows. They are sagittal planes in the mid-clavicular line above the nipple. It can be done very fast. This is a normal view. You have to zoom in What you will see is the bed sign, we call it. These are the shadows of the ribs. And importantly, you will see the pleurae, the visceral and the parietal pleurae sliding over each other in the transversal plane. This is the bed. This is a normal video of nice lung sliding. You see it going sideways in this direction. And if you put in the M mode, we will see the seashore sign. So these are the waves coming in on the shore. So this again is a normal echo of the lung. Well, here we have, of course, a pneumothorax, and it can develop into a tension pneumothorax, especially if we start ventilating the patient. And what we try to do, we put the echo probe on the area where the normal lung goes into the pneumothorax to see the lung point. Here you see the echo view of this condition. Here you see normal lung sliding, and you see here the pleurae standing still. And this point we call the lung point. And the lung point is important because it gives you 100% confirmation of your pneumothorax. If you put in your M mode, you will see the barcode sign. So this is totally different than the seashore sign you saw earlier. You see all these lines continuing all the way down. Okay, here we see a patient who has developed a tension pneumothorax. And this is the patient, and of course you see a lot of subcutaneous emphysema, and this can be a very challenging situation because you have to do several things at the same time. You will probably put in a needle or a chest tube, first a needle, then the chest tube, and you might have to ventilate the patient. So this can be very challenging because the subcutaneous emphysema can be very thick, so you need a very long needle. The other condition you might see, but not really in traumas, I think, is alveolar edema, as seen here on the X-ray. And on the echo, we can see this with B waves, as you can see here. We also call them comets, and per definition, the more B waves you see, the more edema or fluid there is in the lungs. There have been done quite a lot of studies. I didn't really talk about A-lines. A-lines are horizontal lines in the same plane as the pleurae, and A-lines, you see them with pneumonia or CPD and asthma, and the B lines, again, you see them in pulmonary edema. So this is our algorithm. Again, in the B profile with the B lines, the comets, it's pulmonary edema. The A profile with the horizontal lines, you see with these conditions. And if there is no lung sliding and there is a lung point, then you can be 100% sure that you have a pneumothorax. You don't have to make an X-ray. If you do not see a lung point, then you might have something else. You might have a pneumonia, or you might have a bullae. So that's important to differentiate. But again, in trauma medicine, you have your clinic. So you will probably see that the clinic matches your echo findings, and that makes the diagnosis of pneumothorax more easy. So even if you don't find the lung point in a trauma patient, you still have your clinical findings. Again, here are the B lines, the comets. This is a consolidation. This is probably a pneumonia. And on the echo, you will see these signs even with air bronchograms. And here you see edema with B lines. In a pneumonia, you can also see pleuritis. So you can see this kind of pathology. Again, this is what we see in pneumonia with the pleuritis with some effusion. And on the right, you can see an echo finding that correlates with the hematothorax. I will show you this later on. Here's the diaphragm, here's the liver. And normally you would see nothing in the lung because it is full of air, and air is the enemy of echo. So if you see something dark, then it is fluid. And in a trauma, that will be most certainly blood. Again, here is a upper quadrant view of the, well, this could be on the left side actually, the diaphragm, the spleen. Here you see effusion, and what you see very often is a compression atelectasis of the lower lung segments caused by the free fluid. We now go to the upper quadrant and the abdominal windows. So in trauma, you will always do these windows. The right upper quadrant, you go really low, nearly onto the bed, as low as possible. And you put the probe in the sagittal plane and you move it in the craniocaudal direction. I like to find the diaphragm first, and then you see, of course, the liver below it. This is a normal view. Here is the lung. You would see nothing there in a normal situation. And then you have the kidney below it with Morrison pouch. This is a pathologic situation with free fluid between the liver and the kidney in the Morrison's pouch, or subphrenically, and this means in case of a trauma, free blood in the abdominal cavity. Again, if you move the probe in the cranial direction in this window, you might see free fluid with a compression atelectasis in a hematothorax. Yeah, on the left side, you have the same story actually. Again, you go really low, nearly on the bed, and you move the probe in the craniocaudal direction, and you will see the same, but then with the spleen, you might see subphrenic fluid, or you might see fluid in the splenorenal space, or of course a hematothorax. This is the hematothorax on the left side. There is a pitfall in abdominal echo. It will not demonstrate visceral perforation or other abdominal damage other than free fluid. So you might have a perforation of a colon or your stomach with free air. Of course, you have your clinical findings. You will not demonstrate that with echo, and you will have to do a CT scan or explorative laparotomy or laparoscopy. Not all free fluid, of course, is blood. Of course, in a trauma, it will be blood, but it can also be ascites or bowel content or other fluids. The third window for finding free fluid is the suprapubic view. It is a transversal view. Preferably you do it with a full bladder. So we would preferably not catheterize these patients before doing the echo. And here you see a normal finding with a full bladder. It serves as an echo window. And in case of free fluid, you will see fluid collections behind the bladder. We also like to do the abdominal aorta in trauma patients above the umbilicus. It's a transversal window. Here you see a normal aorta, and here you see an aneurysma, and here you see a dissection, which could be traumatic.
So now we continue with your other views. Again, in practice, this will be very fast. You can do the views very fast after each other. But for learning purposes, we will go a bit slower. So again, in the acute setting, we continue with the thoracic views. That's about here. You need to really zoom in to see the pleural sliding. Maybe you can take a deep breath, please. And you see very nice pleural sliding here. So patient has no pneumothorax. In a pneumothorax you will see no lung sliding, and preferably you will see a lung point as a definitive assurance that it is indeed a pneumothorax. If patient has a lot of pulmonary edema, you will see a lot of B waves going down like this, and sometimes in pneumonia you will see A waves going like this. We can also do this on the left side. Of course, you also have your clinic, so you will have a clinical suspicion of a pneumothorax, or even a tension pneumothorax with asymmetric thoracal excursions and a high CVD and patient in obvious stress, etc. From here I usually go to the right upper quadrant, and you really need to put the probe as dorsal as possible, really nearly on the bed. Again, I am playing with the probe. I'm moving it from cranial to caudal. Normally the lung is air, so I will see absolutely nothing, but what I'm looking for is the liver and the diaphragm. And I'm playing with the depth right now, and now is the view I want to have. So this is what I want to see. I want to see the diaphragm here, and I want to see the liver. Now if I move the probe cranially, I see nothing because this is a healthy patient. But if patient has a hematothorax in a trauma, you will see pleural effusion, and usually you will see a compression atelectasis of the right under segment. If patient has free fluid in the abdomen, let's see, I'm going back to my diaphragm, you will see subphrenic fluid, or if I go even more caudally, I am now arriving at the kidney department. This is Morrison pouch, and I will see free fluid between the liver and the kidney in Morrison's pouch. So this is an important landmark for free fluid in the abdomen. We can do this the same on the left flank. Again, first we look for the diaphragm. Here's the diaphragm, here of course is the spleen, and it's exactly the same story as on the right side. First I go up, I go cranially, I look for effusions and consolidations or atelectasis, and I go down and I look for the kidney. Do you have a kidney on that side?
Yes.
Yes. Sometimes people only have one kidney, of course. I see a very nice view of the kidney here, again with free fluid. You will see it subphrenically, or you will see it between the spleen and the kidney. So those are the upper quadrant views. Then we go to the lower abdominal view, and we do a transverse location. This is a suprapubic view. Preferably the patient has a full bladder, so you don't want to catheterize the patient. And you will see the bladder here like a balloon. We can show that on the PowerPoint later. And then in the depth you will see free fluid collections. And I think this patient, yeah, you have a full bladder, so that's okay actually.
Wonderful view.
This is a nice view. So this is of course normal, and with free fluid you will see collections down here. From here we can go to the upper abdomen, and we are looking now for the aorta. I'm playing with my depth again, and I think we have the aorta here. Sometimes I'm not sure, and then I put in a color Doppler. Yeah, I think that's the aorta. And if you have a traumatic dissection or aneurysm, you will see it on the echo, and we can show pictures of those in the PowerPoint later on. To conclude, we will like to show you the suprasternal view, which can help you in diagnosis a type A dissection. This is less known actually. You really have to zoom in, and you have to be a little bit lucky to see the aortic arch. I'm playing with my gain now. So we are trying to find the aortic arch with the suprasternal view.
Sometimes it can help to put the Doppler, color Doppler on it and follow the colors. And you can see the descending, the blue color far from your echo probe will see that is blood going off from you. So the descending aortic, you can find it. And so just follow a little bit the colors, can help to detect and locate the aortic arch, and then
Oh, that's very nice.
you see.
So we Sakir has found the aortic arch, very nice. And in a type A dissection, you can see the dissection flap very nicely. If you want, you can also do a axial view by just turning the probe 90 degrees. This is quite nice actually. So you see that we are continuously playing with the depth and the gain to get the best view. All right, I shall try and show you all the windows in the way we do it in the acute setting. So it's 9 or 10 windows, and you can do it really fast. So again, I usually start with the subcostal. This is the 4-chamber view we showed. From here you can do the vena cava. You can do the axial view. Here's the left ventricle. From there you go to the parasternal. And of course you don't have to do all the movements, you don't have to do all the views depending on the clinic or the situation. Here again we have the parasternal long axis. You can do the short axis, etc. If you want, you can do the apical, and Sakir was very successful in that one. So we have a very nice 4-chamber view. So that took me maybe 30 seconds. Now I'm zooming in for the pneumothorax on the right, pneumothorax on the left, good lung sliding. So it's very fast. I'm going here, thank you. I'm playing with my depth again, looking for the diaphragm. You have to play with your probe to get the good configuration. I like to have the liver on the right side So I see my diaphragm, I see no hematothorax, I see no subphrenic fluid, I see empty Morrison pouch, ready. I'm going to the left side, do the same. I'm going to look for my diaphragm. Again, air, no effusion, no subphrenic fluid, no fluid between the spleen and the kidney. Finished. I go to the suprapubic view. I see a bladder. I see no free fluid. I go to the upper abdomen looking for the aorta. It looks nice, so no problems there. And if I want, I can go to the suprasternal view where my colleague was more successful than I. So this takes me maybe a few minutes, yeah. Sakir?
Yeah, of course.
So it's very fast and reliable. And you don't have to go through the scan or make x-rays, etc. So we would like to conclude our echo demonstration with that for acute medicine. We showed you the 9 or 10 windows. You saw that it's very fast, it can be very reliable, it's not invasive, you don't have to go through the scan, you don't have to make x-rays. Of course, in the patient in traumatic shock, you will have usually hemorrhage. It can be in the thorax cavity, the abdominal cavity, the pelvis or the long bones. For those, of course, you have to make your x-rays, but for the thorax and the abdominal cavity, this is a very useful diagnosticum. Sakir, do you have anything to add?
Now we can conclude that by using echography we can come very far in our differential diagnosis in our patients, very critically ill patients who are in many times in shock when you use your echography adequately. Thank you very much.
Oh, I have an addition, sorry. If you decide to put in a chest tube, I think you should also use the echo because you want to be sure that you put it in above the diaphragm. That's a good thing to do. Also, if you should choose to do a pericardiocentesis, you can probably do the subcostal four-chamber view.
Absolutely, absolutely. You can use it also not only diagnostic as we now showed, but also therapeutic use of the echography is very useful in pericardial synthesis or thoracic tube placement. Yes.
But of course, in trauma, pericardial effusion will be often caused by a dissection, so probably you will have to do a thoracotomy if that's a possibility for you. All right, Sakir. Well, thank you very much for watching, and good luck to you.
Okay.
Our presentation. Again, we sympathize very strongly with you, and we wish you all the best. Also look at the films, please. The webmaster will combine them with these presentations. We hope you enjoyed the webinar and you can use it in your daily practice, and all the best. And maybe you want to say something?
Yeah, I agree totally. I agree with your wishes, and all the best. And I hope we have we have contribute something for your clinic in Ukraine. Thank you very much.